Okay, so for OB/GYN, we will actually start with the OB part. And the first thing we'll talk about is a miscarriage. And this is defined as a loss of pregnancy before 20 weeks gestation. 20 weeks is an important time to highlight, to circle, because it means something special. 20 weeks, we have fetal lung maturity. So prior to 20 weeks, we treat things a little bit differently because there's not a chance, it's not as likely to go on to be a viable pregnancy. It was after 20 weeks, we know that our treatments might be a little bit different because we know the fetal lungs are mature and they could survive extrauterine in a very high level nursery possibly. So 20 weeks is fetal lung maturity. None of this has to do with, you send your patients out, your laboring patients out at 16 weeks or 14 or whatever. This is a physiological time. Your facility might have a certain number of weeks that you transfer or admit them, but that's a facility rule, and that's based upon policy and the resources you have. 20 weeks is a physiological number, actually. The symptoms of a miscarriage can be pretty much anything. There's no one symptom with the exception of vaginal bleeding. So in other words, if you look at 100 miscarriages, the symptoms are just all over the place. It could be abdominal pain, cramping, could be contractions, could be nausea. But amongst all those, a majority of those people, there will be some vaginal bleeding occurring. So that's your most frequent reported symptom. And with any vaginal bleeding for any of our emergencies, we document based on pad counts because it's hard to subjectively guess how much they're actually, is that 500 mLs? Is it 750? We just go by pad counts. That's your most objective measurement tool we're going to use. Now, you do need to know Nagel's rule for the exam. Now, that being said, even though I'm telling you that, I've never have to calculate it on the exam the 6 times I've taken it, or heard from test takers, but it's such a very simple little formula, super easy to memorize. All you got to do is write it down 5 times, flip an index card over, write it down 5 times, say it every time you write it. In 10 minutes, you'll have it memorized, and it's super easy, okay? 9 months plus 7 days, okay? 9 months plus 7 days, or you can reverse that, 7 days plus, it doesn't matter. But here's how you remember that. The 9 is the bigger number, and months are a bigger amount. 7 is the smaller number, and days are the smaller amount when you compare them to months. You see what I'm saying? So 9 plus 7, all right? So learn that, know that, and then as soon as you're done with the test, just throw it out of your memory. You don't need it anymore because we've got computers and pregnancy wheels and things like that. The physical exam for this patient, we might need to look at their orthostatics. There is no questions I've seen on the exam about the right way to do those. Now, if you work with different providers, some want, personally, I just care about a lying and a standing. Some want that middle one. There's still some, there's not a lot of reliable evidence or information as far as what's a positive orthostatic sign. So just know that that's how we check for acute blood loss sometimes. So the how you do it doesn't matter, which is a lot of things on this exam because we do things a little bit differently from place to place or from shop to shop or provider to provider or what day of the week it is even, let's face it. But at some point, this person needs to have a pelvic exam. The provider needs to look at their cervix and see the state of it. Is it dilated? Is it open? Is it closed or whatever? So obviously not an ideal hallway patient, like we have to deal with those a lot. And they're going to need an ultrasound, okay? Now, if you're working at a place where ultrasound is on call or they're not in the department or some places they're having to come from home for this exam, for any of these OB emergencies, ultrasound is like right there and waiting right outside the room. I don't want you to have your day-to-day work practice of, oh, we have to wait for ultrasound, so therefore I would not pick out an exam question. I want you to realize in the perfect world of a perfect emergency room, perfect emergency nursing, that ultrasound is right there, okay? So if it's the test answer you're looking for, go ahead and pick it. Know the difference between your 2 HCGs as far as the fancy word goes. So quantitative, quantity, which means amount, is your serum, is your blood. And qualitative, think of the word quality. Quality means like, how was your service? Was it good or bad? Was it quality service? Was it a plus or a minus? And that's what some of us see on our urine pregnancy test, is a plus or a minus or a positive or negative. So quantitative versus qualitative. Just sometimes those words get a little confused when you're taking an exam, you're kind of stressed out. So if she's Rh negative on her blood type, she needs RHOGAM, which is the brand name for Rh factor immune globulin, okay? And what we're doing here is trying to prevent, basically, I like to call it almost like an allergic reaction of the blood. The blood is like overreacting to itself because the baby is Rh positive and the mom is Rh negative. And if those two blood types mix, then we get this blood reaction. It can be fatal for both of them, okay? So it only happens if mom is Rh negative and the baby's positive. We don't have a way to test the baby. So therefore, by default, we treat all Rh negative mothers. If the baby's Rh negative, it's not going to happen, okay? But we do overtreat. We do treat every Rh negative mother to prevent this. All right, and immune globulins, with that letter I want you to remember, any immune globulin, underline that word, any immune globulin we ever talk about, the letter I means it works immediately because it is actually antibodies being put into the system. You're actually putting antibodies to fight right away. And that's universal for any of your immune globulin medications. So you'll see us use these on a lot of autoimmune disorders too, to actually put these antibodies in there to prevent the body from attacking itself. Okay, so Rh immune globulin for all Rh negative mothers. And then as far as if there's massive hemorrhaging, you're going to see this time and time again. This is a standard or frequent choice of obstetrical emergency care. They're going to look at oxytocin or pitocin first, and you don't need to worry about if it's a bolus or if it's a drip or whatever. Just know that's the first line drug they'll use. You don't even need to know the dose. It varies depending on the situation sometimes. But if they ever ask you for which one would you expect to see ordered first, for bleeding, for dysfunctional bleeding, or the uterine where the uterus is weak, you can always pick the oxytocin first. It helps with uterine tone as well. If she's stable and gets to go home with that intrauterine pregnancy, she's going to be on some bed rest until follow-up. Hopefully this will go on to be a viable pregnancy. And we have to know that it's an intrauterine pregnancy, so we have to have that ultrasound, okay? Now, of course, if she has already had the miscarriage, or if there's some retained products, she may need to be admitted for like a DNC to kind of clear out or clean out that uterus. Or if she's been so volume depleted from a lot of bleeding with this, from only a partial miscarriage, she may get admitted for fluid resuscitation or for blood transfusion. Now, these next two, these are one of what I call the high frequency test items. These have been like every test I've seen. Well, maybe 5 out of 6. Super, and everybody that's taking the test and they give me feedback, they say, yeah, I saw one of these too. So placental previa and placental abruption, you need to know these for sure for the test. And I'm gonna tell you that it's so easy to tell them apart. You just use this little memory clue I've given you. For placenta previa, there's 2 P's. One P is for painless and one's for privates. Well, hey, privates, we're talking about GYN stuff, OB stuff, right? And then the painless, compared to the placental abruption, the letter is going to be always painful. The A from abruption means always, and the P from placental means painful. So, and that's every one of these I've seen, and it's confirmed by other students. That's how you always tell them apart. How severe is the pain? All right, the placenta previa is not necessarily a pain of 0, but it is a much more lower grade pain. Like should not be much more than normal menstrual cramps. The abruption, that's like a legitimate 7, 8, 9, or 10 on the 10 scale. And if I don't say this in other sessions, the CE exam, the patients on the exam know how to use the 10 scale. So if they say their pain is an 8, it's a really severe pain, okay? If they say their pain is a 2, it's kind of there, all right? So you always tell the difference between the pain level. The other thing is to know which one is always the higher emergency. And that's the abruption. Again, you can use that word always to mean it's always the emergency, because this is a fetus in distress because the amount of separation of the placenta from the uterine wall, we're not perfusing and oxygenating this fetus. This fetus is in trouble. Now, the nice thing about the abruption is it typically happens in the 3rd trimester, typically, and that's well beyond the 20 weeks of fetal lung maturity, and it's probably beyond the 30 weeks where we have emergency deliveries. That's another number, by the way, 30 weeks. If there's any pregnancy-related emergency at 30 weeks or beyond, the best plan is to go have the baby. Above 30 weeks, they do very well. Of course, they're going to be in a high-level nursery, and they're preemie. But the benefit of having that preemie at 30 weeks is much less risky than having a mom with a baby still in her having some emergency. Get the baby out. Okay. So placenta previa, painless or pain less than. All right, and placental abruption, always an emergency and always severely painful. And the emergency is the lack of fetal perfusion. So we can get a rapid history, who's your OB doctor, any OB issues, gestational diabetes, things like that. Make sure we're good with the due dates. Hopefully we got some clinic records available, or they've already got an OB doctor involved in their care we can get into contact with. As far as lab tests go, your basic lab tests, I want to mention the Kleihau or Betke test for just a minute. So this is an older test that can still be used, and it actually measures for fetal hemoglobin. So it's actually a separate order. You order in the computer, or the provider would, and it's looking at the blood you took from mom when you started her IV. And the lab, they're going to look and see if there's certain fetal hemoglobin cells there, which actually look different than adult hemoglobin. If you're seeing those fetal hemoglobin cells in mom's blood tube sample when they run it, that tells you that placental uterine junction is disrupted. That blood is exchanging, and it should never exchange. So we have an issue there going on. I've only seen this used once in my career, and it was actually long time, like 20 plus years ago, at a small community hospital where ultrasound did have to come from home. And while we're waiting on them, we went ahead and ran this, because if it was positive, then we'd be like, okay, well, you really need to hurry up and get in here and get this ultrasound done, and tell the OB doctor, you really need to get in here and come deal with this patient. I don't even know if we actually got it resulted in time or not by the time ultrasound was there. All right, let me, all right, so that Kleihauer-Betke test is not something we routinely use, but just know it is a test that could be used. Your preferred test would be to go ahead and get the ultrasound as soon as you could there. Now, anytime mom is in trouble, anytime a pregnant mom is in distress, she goes on her left lateral decubitus side, which is just a fancy word for saying left sideline, okay? And literally on her shoulder, not just tilted, the preferred way would actually be her on her shoulder and her hip, like completely on her side. Okay, get that big gravity uterus off the vena cava, which could be compressing the blood flow coming back to her heart there. And we'll talk about the C-section and the neonate resuscitation here in just a minute. And again, RHOGAM if she's Rh negative. Ectopic pregnancies, by definition, this is anywhere outside of the uterus. Most will actually be in the fallopian tubes. And, I'm sorry, yeah, most will be in the fallopian tubes. And if you had just a little statistical thing, they tend to occur more on the right than the left. So that sometimes it presents like an appendicitis mimic. So that's why it's so important to get that pregnancy test on a female with any abdominal pain, because an ectopic can definitely mimic an appendicitis. Like the miscarriage, with the ectopic, there's a whole list of symptoms they can have. And again, there's nothing specific with this. So we always have to keep our mind open with any abdominal pain in a female. Could this be an ectopic? So that pregnancy test is so important to get. And I've even seen ectopics that really had not even any significant distress or discomfort at all. Just like, oh, I'm kind of cramping down there kind of thing. So we have to keep our radar wide open for this and get that pregnancy test, because there is no specific symptom that says there's an ectopic. Ectopic is defined as you're pregnant and it's not in the tube, which means you have a pregnancy test and you have an ultrasound showing that. Now, for the ectopic, we need to specifically get a serum HCG at some point. You may already have a urine pregnancy test, and that's fine. But we need that quantitative HCG, because that gives us an estimation about how developed those products are. And the radiologist needs that to know if he's going to have a reliable ultrasound. If that quantitative is, depending where you work, usually it's about between 500 and 1,000 is what they want to see to know that the ultrasound will be reliable. If that quant comes back at 100, the radiologist may not even really be able to say, I don't know what I'm seeing here. It's just, there's just not enough gestation to even see anything. Some places may not even do it if it's below 500, because the chance for giving a false reading on the ultrasound. And again, if it's less than 500, it's not like you're going to go home and rupture tonight anyways. So that's why we do it in the ER. Now, having that number done in the ER is nice. They've got it. They can follow that number up in the clinic when they get discharged. They can follow it down to 0 if they miscarry. But that's why we as ER people need it. I need about 500 to 1,000 to know that it's going to be a good, reliable ultrasound and able to be interpreted. And of course, it's going to be a transvaginal ultrasound. They'll still do a transabdominal part, looking through the abdomen, but we also need to do it through the vaginal canal to get that probe as close as they can to those very small, early gestational areas. So just the regular ultrasound, we need to specifically have a transvaginal component to it. Now, the definitive treatment for an ectopic would be surgery. Okay, going to OR, actually taking the tube out on the side where the ectopic is and removing it, and then sewing it up and sealing that off. Now, it's an invasive procedure, risk for infection, risk for bleeding. A lot of times it's an emergency surgery, meaning anytime you go to surgery from the ER is much higher risk than elective surgery. So an ectopic surgery is usually an emergency surgery, so it's much higher risk for complications. Sometimes they consider, is this a candidate for methotrexate, which by giving them this medicine is basically causing a chemical, what's the word I'm searching for here? It's not Is it an abortive or not? That's not the discussion, because an ectopic is not considered viable. We don't typically, you don't abort a non-viable product of conception because it's not viable tissue. So that's not the discussion here. So it does cause them to expel the pregnancy. It's an injection. There's no questions on the exam about can you give it? Do you have to be certified? Do you have to be qualified, trained, whatever? It varies from place to place, and it may be regulated by your state board of nursing. It may be related by your hospital policies, your med staff privileges, things like that, as far as your local control systems. So that's not going to be on the test. Just know that methotrexate is an alternate to surgery. That means they're going to get the injection. They're going to go home. They're technically still having the ectopic when you discharge them, but it should expel within the following hours. And we'll have to educate them that you're going to have some cramping, some bleeding, some nausea, things like that. What's the benefit of getting methotrexate? Anybody want to type an answer there and give me a guess? What would be one benefit? Of course, the benefit of not having an invasive procedure and the risk for surgery, but think down the road for this young lady. What's the benefit to her and her future health by getting the methotrexate and not having her tube tied and that ectopic surgery? Yeah, so she still has both tubes, so her chance for fertility and having babies is higher. Exactly. Because obviously if you only got one set of tubes, if you only have one tube, you've got less chance for a pregnancy to occur. So sometimes that's an option, but again, we're talking very early ectopics, and it has to be a very stable patient with some very good follow-up. You just don't want to, do you believe every candidate is a candidate to go home, with methotrexate? Do they have an IQ that they know what to watch for? Do they have a relationship with an OB doctor? Things like that. So not everyone's a good candidate for that. So I've only seen it done a handful of times my whole career. Of course, a lot of that career, I worked at a large teaching hospital. And if you don't know, at teaching hospitals, they tend to lean towards doing more of the procedures and stuff because they've got a lot of residents to do them. So methotrexate is a possible alternate with the benefit of saving the tubes. All right, our pregnancy hypertension emergencies. So we start with pregnancy-induced hypertension, or PIH, and that's just defined as being pregnant and then with an elevated blood pressure. Pre-eclampsia is the PIH plus evidence of that blood pressure causing some effect on the female or the baby. And then eclampsia is pre-eclampsia now with seizures. So now it's affecting the central nervous system. So it's just a progression. You don't get eclampsia without having had PIH at some point and starting that whole chain of events. Okay, so what we hope to do is identify these young women early when it's just PIH and have OB work with them and try and keep it under check and under control. Now, the concern is when we talk blood pressure under cardiology emergencies, we talk about blood pressure emergencies being not just a number, but the damage to certain organs. We call that end organ damage. When a female is pregnant, now the placenta and the fetus are another end organ that's being affected by the adverse effects of blood pressure. And the concern here is that the placenta may not develop correctly. It may not work correctly to not allow the baby to progress. We see things like growth retardation, possibly some oxygenation issues, things like that, because the blood pressure is affecting the placenta and the fetus. Of course, it's also affecting her. Could put her in some renal issues too. So preeclampsia is the pregnancy and the hypertension. And one of the most common symptoms we'll see is protein in the urine. So we want to get a urinalysis on these pregnant girls, not just for a pregnancy test, but also to actually do the full UA and see is there protein leaking out. Because if there's protein leaking out and her blood pressure meets the numbers, she's now actually preeclamptic, not just PIH anymore. All right, and now this kind of changes her disposition follow-up. Rather than her just following up in the clinic this week, your ER attending is probably calling the OB service or OB attending or whoever and saying, hey, I've got a girl, she's preeclamptic, they're going to put her in. So that protein in the urine makes the big difference that you're actually in preeclampsia. And eclampsia is when it's now progressed and affects the CNS, they're having seizures. Obviously, a seizing mom is not good for the baby because she's clamping down and she's not perfusing the uterus, the placenta, and the fetus the way she should while she's seizing. Now, HELLP syndrome is actually a big whole condition, but it's very easy to identify and to define for us and to know what to watch for. You just look at what the words stand for. So hemolysis means she's going to have a low hemoglobin. So she's lacking some oxygen carrying capacity. Elevated liver enzymes. So her liver is starting to show stress and strain from the blood pressure. And then low platelets. So she's at risk for bleeding. So thrombocytopenia, okay? And that's basically all we need to know about this. And if we need to treat her, that's what we're going to address. She might need a blood transfusion for the profound anemia. She might need platelet packs ordered from the blood bank, depending on what's going on. They'll typically be admitted. The blood pressure guideline is still 140/90, just like when we talk regular cardiac emergencies. But in pregnancy emergencies, we have to add a second defining characteristic, which is it's either 140/90, or if the systolic is 30 from her baseline or 15 from her diastolic baseline. Because some of our pregnant patients can be small people, like a 12, 13, or 14-year-old can get pregnant if they're menstruating and having sex, right? And it's possible that a 13-year-old could weigh 110 pounds soaking wet. Just these thin, skinny, kind of mid-puberty girls, and that her blood pressure could normally be 100/60 on a healthy day. And she comes in at 130 systolic, and you're like, okay, well, that's not the 140. But for her, that 130 is 30 points above her baseline of 100. That's a 30% more stress being put on her tiny body and her organ systems. So that's a fair amount. So you do need to know that second criteria just for the pregnancy emergencies. Now, how many 13-year-olds know their blood pressure? None. If the ENA was going to ask you this specific teaching point, they'd have to tell you this person's baseline blood pressure, because that's not fair for you to assume, oh, it's a small person, she could normally be just 100 systolic. They'd have to tell you. So the lab test, the minimum we're going to do for any of these is at least the urine looking for the protein, okay, because that usually doesn't cause symptoms. Sometimes people don't even know they're leaking protein, and that's that sign the kidneys are being affected by the blood pressure. All the other tests are going to be case-by-case dependent. For example, girl comes in for some pregnancy-related problem, and she's already followed by the clinic, and they've been telling her, well, we're watching you for HELLP syndrome. Okay, well, I need to start redoing some lab tests here in the ER to see if it's progressing. What if she has HELLP syndrome, and she, on her way to her OB clinic appointment, she crashed her car and hit her head on the windshield? She's getting a CT of the head because those low platelets, right? Because a dead mom from a subdural or subarachnoid is not good for a baby. All right, so it's on a we don't need to do everything for everybody, case-by-case basis, but I would tell you the minimum is at least to check the urine for the protein, because sometimes that may be the only thing that changes it from PIH to preeclampsia. Same ABCs we do for everybody else, we'll do for mom. And again, remember, if she's in any distress, any signs of shock, left lateral decubitus or left side-lying position, and then there's your 30 weeks. So at 30 weeks, any obstetrical emergency, we need to consider, should we go have this baby and just have two separate patients rather than one patient tied to the other one, basically, dependent upon mom's survivability. For medicines, treating anywhere along the preeclampsia, eclampsia spectrum, this discussion here is also an example of how you answer these test questions. We always go from the safest, less risky, less side effects, less invasive, to the more. All right, so we're going to start with something simple here, like mag sulfate. All right, you do not need to know the dose, you do not need to know the rate, things like that. You just need to know that would be the first drug you expect to see on a preeclamptic patient. Okay, and it's going to work. One way it does work, it helps to reduce some of the arterial bed constrictions. It helps to reduce that blood pressure some. It helps to protect the CNS also, possibly from those seizures if she would become eclamptic. The only thing I want you to know for mag sulfate for the exam is not the reflexes, but does anybody want to guess, what is your worst finding of mag toxicity? What's the worst symptom or sign a patient can have with mag toxicity that we have to remain alert for? It has nothing to do with reflexes. Again, there's about a 2-second delay, so I'll wait a second, see if someone wants to guess. So what's the most concerning finding of magnesium toxicity? Yes, respiratory effect. So hypoventilation. So today is not the day that everybody gets respirations of 16. That's on mag. We actually count them. And how do we reverse it? We turn it off. It's like a trick question. What's the treatment for mag toxicity? Is to turn the drip off, because you don't get mag toxic any other way. Next line drug would be some benzos, Valium, Ativan, etc., trying to calm the CNS. Before we get to, of course, if she's seasoned, we got benzos, but we don't want that to happen. The concern with benzos makes them a little less safe is we're going to cause some respiratory depression in her, possibly. And if we suddenly go to a precipitous delivery, that baby may have some of the effects of those benzos on board with mom. And of course, you know, we might end up having to bag mom if the benzos are too strong. The OB doctors like hydralazine, presaline a lot for pregnancy blood pressure issues. Again, you don't need to know any dosages. Just know if that's all you know, it's a 3rd trimester patient, pre-eclamptic, what vasoactive drug might you expect? I'm lean right towards the hydralazine and the presaline. It's just a preferred one of theirs. Labetalol is an alternate. Of course, that's a beta blocker, so you gotta watch the heart rate. Nipride would be like the last one we'd ever consider if she's like in some hypertensive crisis, because nipride can be toxic to the fetus. But if mom's seasoned from that blood pressure, we've got to do something at some point. All right, hyperemesis means lots of vomiting. This is not just the morning sickness. This is the 24/7 sickness, all day long. Can't keep fluids in, can't keep any food in. So she's dehydrated. She's got no carbs coming in because she can't keep stuff down. So she can go basically into a keto diet, you know, or an Atkins diet or whatever. And it's the ketones that are building up from that that can actually make things worse. Ketones actually make you nauseated. Just jet go overhead here. Ketones actually make you nauseated. And that makes this part of the downward spiral here, that the more she gets ketotic, the more she gets nauseated, the more she's vomiting, can't keep stuff down. Because of all that dry heaving now, remember her gut's empty, so she's just dry heaving all the time, just, you know, nothing coming up. You can actually tear your upper GI tract, and that's called a Mallory-Weiss tear. We've actually got a rupture in your upper GI. Of course, there's going to be an associated risk of GI bleeding with that, as well as contamination spreading into the peritoneum. All right, so the dehydration and the ketones are the problem here. That's what I want you to take away with this. So our first thing, first under our assessment, we're going to see some evidence of dehydration. We might see her BUN and creatinine showing maybe even acute renal failure or acute kidney injury from the profound dehydration. Whether you check serum acetone or serum ketones or urine ketones, they're both going to be positive for this exam. I know some places it just depends how ketotic they are, whether they both show up or not. That's the zebra in the desert. We're not worrying about that. If this person is in hyperemesis, both the serum and the urine will be positive for ketones. All right, so initially we need to get some fluids in this person, not necessarily because she's hypotensive, but because she's actually intracellularly dehydrated also. In other words, the water's coming out of her cells. And when a cell, let's like say your intestinal cell doesn't have water in it, it doesn't do its job effectively, it doesn't absorb. When your lung cell doesn't have enough water in the cell, then it doesn't function as well to make the ATPs in the mitochondria to do its job of exchanging CO2 and oxygen. So intracellularly dehydrated is the more common thing with this. They're not always hypotensive and passing out, but those cells, so we're going to start with some normal saline, and then at some point she needs something with dextrose in it, something with D5 or D10 running, because she needs carbs also. But if you had to pick the first thing to do, you get plain isotonic fluids, because that intracellular dehydration is so important. Also, giving those fluids will help dehydrate or dilute some of those ketones, which may actually help reduce some of the nausea as well too, which is kind of nice. Remember, ketones make you more nauseated. All right, medicines. So we've got a bunch of nausea medicines here, and as I've been doing these lectures, officially every form of Zantac is off the market now. They were still allowing some IV ones, so I'm going to actually change this while we're on the screen. So anytime in my lectures you still see Zantac, I want you to take that and just change that to Pepcid. So Pepcid is our go-to H2 blocker these days. Now, I still have Zofran on here. Zofran is still considered safe. All right, there are some issues they're looking at, and they're doing some evidence gathering, some data gathering on it, but it's not been proven that Zofran is, as of yet, a causation for problems. There is an association with some bad outcomes, but association is not the same as causation. So for right now, Zofran has not been pulled, it's not been black labeled, but a lot of your providers are moving away from it just to be safe. So, and that's a provider choice, okay? I still use it, okay? So for the CEN exam, I don't want you to think, oh, we don't use Zofran anymore, I can't pick this. You can, it's not been FDA restricted yet. Postpartum will be, now with any delivery, there can be some bleeding, but this is defined when delivery is done and delivery is not done until the placenta is delivered. And now the delivery is finished and she's having bleeding and it's causing her to be unstable. That's the criteria for this. Has to be some instability, because there's bleeding happens with every delivery potentially, but not every mom gets unstable, i.e. going into shock and dropping their blood pressure. Now, when it does happen, the most common cause, 9 out of 10 times, is just a weak uterus that's not clamped down. And there's a fancy word for you there. This word atony or atony, I don't know how the right way to say it. Anytime we have these Latin medical words, the prefix a means without. So this is without tone. So the uterus is weak. It needs to clamp down. So our number one treatment for postpartum hemorrhage, 9 times out of 10, is going to be fundal massage or uterine massage, trying to get the clamp down and seal off those bleeding vessels. So, and again, that's our paradigm of trying something that's safe, non-invasive, less costly. So on any postpartum hemorrhage, we're going to do fundal massage first. And of course, if it doesn't respond, then we're going to go back. There's that OXYTOCIN again and the METHERGINE again. Again, PIT would be the first line drug, but we're still going to try the non-invasive, free, less risky things first, especially since it's going to fix a large majority of the cases. And again, you do not need, if you've not had any other lectures with me, there's very few dosages on this test. We've still not even mentioned any dosages yet in this lecture. You just need to know which drugs you might expect to see ordered. All right, let's talk about delivery now. Now, for us, it will be an emergency delivery, because preferred, if we have time, that patient's going up to the L&D suite or getting transferred out. So an emergency delivery is a delivery that's going to happen now, and we don't have a choice in the matter, and we need to go right into a room and do some things. So other than these frequent contractions, about 30 seconds coming every 4 or 5 minutes, there's other physical findings too. Like if you look down there and see crowning, if you look down there and see a limb presenting, if you look down there and see what we call a bulging perineum. Bulging perineum is a medical word that says basically you're fixing to see crowning any second. In other words, that normal perineal area that's kind of flat, it looks like it's someone's fixing to come out, a bulging perineum. Now there's 3 stages of delivery. Now this is per the ENPC. Anytime something differs between either the ENPC class or the TNCC class, which are your ENA 2 big classes, versus another organization, we go with what the ENA classes say, because ENA and the BCN are pretty much buddies. Other pediatric classes give you 4 stages of delivery, but ENPC still teaches 3. All right, contractions to dilation, dilation to baby coming out, and then stage 3 is the placenta. And that gets forgotten a lot of times. You know, we think that's not really part of but the placenta is part of the childbirth process. Because even if you look back at the postpartum hemorrhage, remember that's defined as it has to be after the placenta is delivered. Because if the placenta is not delivered yet, that could be the cause of the bleeding. It's still partially attached. So critical thing for the exam, stage 3 to finalize delivery is the placenta itself coming out. Now there's several delivery emergencies we can have. There's only one that's a true game changer. And because it's a true game changer, that one gets assessed for and dealt with every delivery to make sure it's not there. And we're talking about the cord emergencies, whether it's a prolapse cord or a nuchal cord or a strangulated cord. Any cord emergency just ups the entire game to a whole nother level of seriousness, okay? Because the potential for compromising the circulation of that baby as they're passing through the birth canal. So for every delivery, we're going to check for a cord. That's mandatory. Now, if you see the cord laying there, well, you know what the problem is. If we don't see a cord as the delivery is happening, one person puts 2 fingers in, and they're going to try and feel around the head and the neck to make sure that even though they can't, someone coming out the canal at the same time. If they don't feel one, they can take their hands out of the vaginal opening and they're done. If they do feel a cord, their job is to keep their hand and fingers there, trying to keep pressure off of it as the head and the neck is delivered. They don't want it to be compressed. Now, if the head is out and they notice the cord is being compressed, they don't feel any pulsations, that means there's no perfusion to the baby, we can go ahead and cut that cord now, even though the rest of the baby's not delivered yet. If the head is out, we go ahead and cut that cord, and they'll start doing the baby's airway even while the delivery is continuing. Okay. So we're going to wipe the sweat off our brow, and we'll say, oh, there was no cord there, so we're good. Baby is delivered. Every delivery, again, this is an ENPC specific thing. NRP, Neonate Resuscitation Program from American Heart, they have this a little bit differently. They don't mandate suctioning for every birth. ENPC still says you do. So we're going to go with that. So every baby you deliver on this exam, you will suction them, and it's a specific order. Mouth before the nose. That's alphabetical. Letter M comes before letter N. The rationale for this, and the reason why this is a potentially good test question, if there was some meconium in that amniotic fluid, what you don't want to do is suction the nose first, because there's still fluid in the oral pharynx in the baby's mouth. And if you suction the mouth, maybe the baby might kind of cough and sputter. And we don't want them to draw more of that meconium into their lungs. So if we do the mouth first, that removes that big old wad of fluid from their oral pharynx. And then now we go back and do the nose. And if they do cough and sputter, the oral pharynx is clear. Okay, so alphabetically, mouth before nose. And this is just the bulb suction. It's usually either a green, a yellow, or a blue one. It's basically like an infant snot sucker that, you know, the kids go home with, and they have like RSV and stuff and all the snotty noses. It's just that bulb suction, okay? We're not doing tracheal suctioning yet. That's coming. Normal delivery, we support the head, and it usually comes face down. Naturally wants to turn to one side, and we just support that head and neck, and the rest of the baby's born, and things go very nicely most of the time, like a lot of the time, actually. It's only about 5 or 6% of all these childbirths that need anything more than just the basics of the suctioning, drying them off, and keeping them warm. So every baby gets those three: dry and warm, stimulate, and suction the mouth and then the nose. Now, APGAR score. You do not need to know the numbers for it, and there's no scale or score on this entire CEN exam that I've ever seen that you actually have to score it. But I have seen times where they're asking you for what parameters or what things you're looking for. What are the components of it, basically? All right. And the other thing is, you don't do the APGAR at the moment of birth. You wait a minute, because that first minute you're stimulating, suctioning, warming them, things like that. And what we want to see is at 1 minute, hopefully we see some positive response, and then again at 5 minutes. Okay. So I did it as a fill in the blank for us here, so we can go over the letters and what they stand for. So you're going to assess A for appearance. And initially, they may be a little dusky, a little pale, because they're not really perfusing yet. But that's okay. It hopes to get better at 5 minutes. P is for pulse. I'm going to recommend that you remember the range of 140 to 160. And there's a reason for this. 160 is a little bit high, but it's going to make it easier when we tie it to respirations in a minute. G is for grimace. That means you're going to look at the baby's face. And if the baby's kind of squinting at you, kind of making a fussy looking face, that tells you their central nervous system is oxygenating, because they can tell that this loud, noisy, can I even say Chinese fire drill anymore? I don't know. But you know what I'm saying? This chaos going on in this room here. The baby's like, I don't like this place. Put me back in the hot tub I was just in. So it tells you their brain's perfusing. So grimace. Next letter A is for activity. And that is looking at muscle tone. Within a minute or 5 minutes, I eventually, if they're oxygenating, I want to see them start to pull their arms and legs towards the middle, towards the core. That's a protective posture for a baby. It's just almost like a reflex. It keeps the warmth trapped, and it's a safety thing too. The limbs are protected. So motor activity. And then last R for respirations. If you do the pulse of 140 to 160, for respirations, just drop 100 from that. So a good respiratory rate for a neonate, a newborn, 40 to 60. Again, 60 is a little bit high, but it makes it easy to tie that to that heart rate number. I don't want to see respirations of 20 on neonate. That is not enough. 30 is still low. So 40 to 60 gets you a good range there. All right. So we had appearance, pulse, grimace, activity, and respirations. All right. So just know the words and those couple numbers, but you don't know how to score it. All right, so 95, 96% of the time, everything goes fine, and all we have to do is just the top step here, and we're done. We're happy. Get them out my ER and up into the OB floor, or transfer them to a women's hospital, right? All right, the other 4 or 5% of the time, we have to do some other stuff, and this is the order we do it in. All right, so remember, every birth gets the dry, stimulate, warm, and the oral suctioning. Well, it's actually oral. I should just put the oral, nasal oral suctioning. All right, if after a few seconds we reassess them, they're not starting to perk up and really respond to this, we're going to suction a bit deeper. This is where you have to get the long, thin suction catheter, not the rigid one, not like the tonsil tip or the yanker, but a thin suction one, a little flexible tube, and we're going to go a little bit deeper down the trachea, and we're going to reassess. If they're not really responding, they're not pinking up a little bit, all right, I'm going to keep their airway open if I need to. And it's just, here's the key, is blow by oxygen before ambu bag. So they may not even be breathing. They may actually still be apneic, and you got to resist the urge to do the ambu bag first. It's blow by first. So if they do take the first breath on their own, it's going to be 100% oxygen, not the 21% in the room, because you're putting 100% right in front of their face. Now, you can do this with the neonate ambu bag on high flow oxygen, but you're just not pressing yet with it, because we want the babies, if possible, to take their own first breath by negative pressure. We don't want their first breath to be positive pressure. One of the downsides of that is we could be putting more meconium down to deeper distal airways. Another thing is, by positive pressure, some of those initial circulation changes of the shunting of the blood and the valves closing, all that, it doesn't work exactly the same with positive pressure, all right? So the basics, reassess. Tracheal suction, reassess. Blow by oxygen, reassess. Positive pressure, here's that rate again, 40 to 60 a minute. So it's about almost a little less than 1 a second. So pretty fast. Now that I know I'm getting oxygen into their lungs, now I look at the heart rate. Above here, the heart rate doesn't matter, because your number one cause of bradycardia in kids is always an oxygen delivery problem. So we've done all our oxygen steps to make sure it's going into the lungs. Now I check the heart rate. If it is 60 or less and it's not coming up, we start compressions. And the rates between 100 and 120. Basically, most books you read will say at least 100. The goal is 120. It's hard to get 120 because that's basically 2 a second. All right, so it needs to be at least 100, shooting for 120. At that point, we need definitive airway control, and your best peds intubator needs to come do their thing and secure that airway definitively. Now, because we're doing compressions, that means we're going to need some drugs. So really the only drug we need for peds resuscitation is the epi. Now, this is one of the few drugs you need to know for the test and the dose. You can write it down here. It is 0.01 milligrams per kilogram. It's a standard dose because it's weight-based. Or another way to say it is 1/100th of a milligram per kilogram. Now, if we're doing compressions and we've got this baby intubated, why are we giving epi? I want you to, there's a lot of good reasons for epi. There's about 4 or 5. I'm going to go through them if you want to write them in the margin there. All right, number one, epi is going to increase their cardiac output. Infants only increase their cardiac output by rate. They do not have the contractility or the stretch that an adult does. If any of us have a low output state, one of the things our heart does, it goes up in the rate also, but we can actually, the sympathetic system makes our heart actually contract stronger. Infants can't do that. So they need the rate control with the epi to increase the rate. Epi will also cause their blood vessels to tighten up in their periphery. What does that do? That increases the blood pressure, which increases the pressure to, perfusion to the organ systems, their kidneys, their liver, and things like that. So it's a vasoconstrictor. It's a heart rate increaser to increase the output. Epi also works to bronchodilate the lungs. Why do we need to do that? The likelihood that you're resuscitating a child, an infant, a neonate, just by default suggests it could have had some birth. In other words, a lot of preemies have to get resuscitated, all right, or have some lung developmental issues from birth. So epi is going to do good as far as expanding that functional lung space with the bronchodilation. Epi will also increase their cerebral blood flow to protect their CNS, because let's face it, we've already been doing some resuscitation here for a couple minutes, and that's less oxygen going to the brain than they normally need. So epi increases cerebral blood flow. And the last thing, epi increases the release of glycogen from the liver. And what we know about babies is they have limited glucose stores as it is. And what have we been doing here the last couple minutes? We've been burning up some of their glucose. So if I can force their liver to kick out a little more glycogen as a backup source, that's a good thing. So 5 good things to epi for resuscitation of a kid: heart rate, vasoconstriction, blood flow to the brain, glycogen conversion and release from the liver, and the bronchodilation. And I think there's a reason for every one of those that applies in this scenario here. So 0.01 milligrams per kilogram. The other two are on a case-by-case basis as far as the Narcan, the glucose, not routine, but the epi will be. All right. All right. Whew, delivery's done. Let's go to something less emergent, less stressful, right? So dysfunctional uterine bleeding. So the first thing we have to do here is rule out pregnancy, because pregnancy and bleeding is a whole nother flow sheet and a whole nother pathway. All right. So this is a non-pregnant female having bleeding when she shouldn't. Now, your top two causes universally are either uterine fibroids or hormone irregularities, neither of which we can really test for in the ER. Fibroids don't always show up on ultrasound. So we can assume by default, unless there's some other compelling indicator, like she had blunt trauma with a steering wheel, all right, it's either gonna be fibroids or hormones, and that's why our treatment is the progesterone at the bottom there. Now, the one life-threatening cause that it could be is uterine cancer. And that's why it's so absolute she has to have follow-up for this. We can't diagnose uterine cancer typically today in the ER. Our job is to make sure she's not anemic enough that she needs admission for blood transfusion, and basically make sure there's no other proximate cause for this, and then start her on progesterone. All right, and this is key. It has to be progesterone only. So it's not the normal combination. Most your normal common blood pressure, birth control meds are progesterone and estrogen combined. Progesterone is the turn-off chemical. It turns off the uterine lining. It turns off the bleeding. Estrogen starts it or keeps it going. That's why when a girl's on birth control, it's artificially controlling that cycle. Progesterone for a certain number of days, estrogen for a certain number of days. All right. So for this one, you do not want the estrogen component. It's the progesterone only. So highlight that. That's important for the test there. There's no specific names for it. It would be listed as progesterone. And then we have to tell her about she needs to have follow-up to rule out cancer. Again, especially if the endometrium or the uterine lining is hypertrophied with this bleeding, even an ultrasound or CT is not always going to show us the early findings of uterine cancer. So typically don't find it at the first stage. Fortunately, it's a very rare cancer, but it is something that because here's the thing, the progesterone is going to work. It's going to reset her uterine clock. It's going to reset her uterine cycle, if you will. The bleeding will stop, and she'll be like, oh, I feel fine. You know, after a week of taking this medicine, I feel fine. I don't need to see anybody. But what if there's already some mass growing in there? And now she does not go for follow-up. And then she comes back to the ER when she's like systemically sick. She's, malnourished, all this weight loss, and, and she's got metastasis. All right. So we treat with progesterone. She has to have follow-up to rule out uterine cancer. Also, they want to do the ultrasound when the bleeding stops so they can get some better pictures too, after it's kind of already sloughed off some of that inner lining there. Okay, our PID patient. So it's either pelvic infection or pelvic inflammatory. The words are kind of interchangeable. The infection causes inflammation of the structures. And we're going to be treating gonorrhea and chlamydia for the most part. Now, not all of us are doing the immediate test for these. Most places are still doing the pelvic swabs. They take a couple days for the lab to process. So we're always treating for gonorrhea and chlamydia empirically, meaning all arrows, all signs, all indicators point towards PID. And we know that GC and chlamydia are a huge component of that. So we're going to go ahead and treat for it regardless. All right, that's called empiric treatment, when all the road signs point towards something, you just can't prove it today. It's like sometimes if you ever seen your provider, maybe in a fast track setting, just treat for strep throat without a strep screen. What they're basically saying is everything looks, smells, quacking like a duck that it's strep throat. I'm going to treat you. That's called empiric treatment. All right. The concern with PID is it can actually get knocked down and go subacute, still be contagious. And hey, why do they have PID anyways? Well, high-risk lifestyle is one of the reasons they have it. And there's a good chance that if they're feeling better and it's subacute, they're going back out and being risky again and spreading it around or causing it to flare up, basically. All right. Long-term concern here is the risk for ectopics, because it actually can leave some scar tissue in the fallopian tubes. And if your fallopian tube has some scar tissue, there's a chance a fertilized egg can get stuck there and not make it into the uterus. All right. So if you keep seeing the same young girl, you know, on a regular basis, you know, it's her third PID in 2 years in your ER, you might say, hey, if you ever want to really have babies later, you need to knock this out and actually start, you know, taking care of yourself, because you're really stacking up the odds that you're not going to have, you know, viable pregnancies down the road. Symptoms, there's going to be some abdominal pain almost always, but again, the one that's not having abdominal pain, that's the zebra in the desert. But pretty much for the most part, as far as what the patient reports, abdominal pain is pretty common. What we'll see is the discharge. All right, now the patient may not notice. I've had plenty of young girls tell me they're not having a discharge, and we get down there and do a pelvic exam. I'm like, really? And I've heard them say, well, I thought that was normal. Well, I guess if you have it all the time, you might think it's normal, right? But so we're going to see that on physical exam, because as they're infected tissues, and infected tissues give off drainage or discharge. So that will be there, although sometimes the patient, or maybe small enough the patient doesn't notice it or not really pay attention to it. But so symptoms are kind of non-specific here also. On that pelvic exam, when we check the cervix, they're going to have some cervical tenderness. That's when the provider puts the 2 fingers on the cervix during the bimanual part of the exam, and we're actually trying to bounce or press on that cervix. And if it's infected, it's going to be very painful. Sometimes so painful, they may actually, what we say, jump off the bed and grab the chandelier. It's not really a medical term. It's kind of just a tongue-in-cheek term. You might hear people say, oh, chandelier sign in 4. It means it's so painful in that pelvic exam. Heel jar. This is why they shuffle. They don't want to let their heels hit the floor, because when you're walking and your heel hits the floor, it sends a jarring sensation up to the peritoneum. And if their PID is so established, it may be they may tell us like the ride to the hospital was very uncomfortable, all the bounces in the road. So these are signs of peritoneal irritation, that jarring type sensation. So that's why they slide or shuffle in. All right, absolutely got to rule out pregnancy, because pregnant and PID gets admitted because this is going to be a high-risk pregnancy. They're going to go on a couple days of IV antibiotics in the hospital, and the OB do some assessments and establish a safe plan of care for them. But pregnancy with PID gets admitted for the initial diagnosis. All right, we give the Rocephin to kill the gonorrhea and the Zithromax to kill the chlamydia. Again, you don't need to know any dosages. I already know it varies from place to place what we're using for Rocephin. Some places are using 1,000, some places 250, some 500. It just depends upon the provider and what the prevailing local disease penetration is. All right, so you don't need to worry about dosages, but be able to pick Rocephin and Zithromax out of that list there. As far as the flagell goes, we only need that if they have trichomonas. Now, we will know that at the time of the exam, because that's not the DNA swab that has to be processed. That's just the glass slide that they put the specimens on, and the lab tech actually looks at it. It's a visual diagnosis under a microscope, and if they see trick, they'll tell us, and that patient will get flagell also. What's a patient teaching point about flagell? I'll let y'all answer this. They need to avoid what if they're taking a flagell prescription? During the course of flagell therapy, they should refrain from alcohol. Very good. It can cause a nasty GI reaction, like profound vomiting and just awful. Okay, so if they're going home on any extended antibiotics, and this goes with anybody on antibiotics, as you guys all know, we remind them, take all of them even if you're feeling better. Any STD needs an HIV test at some point, because if the door opened for one thing, it could open for everything. Not routinely done in the ER. Some places can do it, but just know the standard of care is at some point, either in the ER if you do it, or at their follow-up, they need to have an HIV test. They need to know their status. Okay, and also every STD needs a test of cure. That means a re-examination, a re-swabbing to prove that stuff is eradicated. Because remember, some of these can go subclinical. Patients feel fine for weeks or months or longer, but still spreading germs. So for any STD, HIV testing and test of cure at some point. Our UTIs. So UTI is the big name for anything from the kidneys all the way out and down to the urethra. And along that entire tract, it's E. coli predominantly. All right, so I do want you to know that, because the thing is, one of the reasons or the risk factors, where does that E. coli come from? it can come from the perineal and the rectal area. And that's one reason we teach these females to make sure they wipe from front to back, not from back to front. Let's not be dragging the E. coli up to the urethra there. All right, so it's E. coli everywhere you slice it, 80% of the time. Now, for men, all right, so all right, let me back this up. For women, the #1 cause of dysuria in a woman across the entire age spectrum is a UTI. #1, that's not saying it's the only thing, but it is the most likely thing, okay? In a male with dysuria, it's more likely either an STD or a prostate problem. Those are the top 2 for men. UTI is actually the 3rd one for men. Men don't typically get UTIs. It has to do with the relative longer urethra is more protective. A female urethra is only about 1/2 inch long, so it's more easy for germs to go up 1/2 inch versus a couple inches long, with the urethra through the penis. So it's more protective in men. So women, #1 dysuria, UTI till proven otherwise. Men, the #1 and #2 is either STD if they're younger or prostate if they're kind of 50-ish or older. And if they don't fit either of those 2, then it could be UTI. But that's the opposite relationship for men versus women. And all the symptoms of the UTIs, these all have to do with how the bacteria is irritating the bladder and the urethra. We call these irritative voiding symptoms. The tissue's irritated, can't go, hard to go, can't start, can't stop, can't empty completely, have to go right away. These are all irritated tissues because of the bacteria growing there. Now, if they have something else with it, other than just the voiding symptoms, they're having some back pain, some nausea, we need to think, could this be a pyelo actually? Because a kidney infection, the kidneys affect a bigger part of the body, and the symptoms tend to be a little more systemic. So a true simple lower UTI is just usually the localized symptoms of the voiding, and pyelo is that plus possibly some other more systemic symptom. We have to worry about sepsis with that. There's urosepsis that can happen. All right, they might have suprapubic. Now we got to be very specific with this word. Suprapubic tenderness literally means you're putting your fingers right on the pubic bone and just sliding them just above it. Okay, you're basically trying to put your fingers on the dome or the top of the bladder and put pressure there. All right, if you're getting tenderness anywhere around the umbilicus, that is well above suprapubic. That's like mid-abdominal. So suprapubic is a very specific location. And then CVA tenderness, if we're thinking the kidneys, you might see us kind of turn them on their side or sit them up and kind of lightly rabbit punch or jab them or percuss where the costal vertebral angle is. That's where the ribs join the spine, because that's where the kidneys sit. We're trying to elicit some kidney tenderness possibly with this. All right. We need a urinalysis. You can't diagnose a UTI without a urinalysis. And if you only get to look at one thing on that urine report, look at the nitrites. It's going to be the most useful. Okay, nitrites are a byproduct of bacterial metabolism. So the logic is no nitrites, no bacteria. Positive nitrites could be bacteria. All the other things we might see on there are hit or miss. You could have hematuria with an infection or not. You can have leukocytes could be there from some inflammation. White blood cells could be from inflammation. Nitrites are a specific byproduct of bacterial metabolism, so that's your most useful if you only get to look at one of them. So a lot of times providers will just treat, even if the nitrites are anything positive and everything else looks fine, they'll go ahead and treat because that's suggesting there's a possibility there's bacteria there. Of course, we got a urine culture usually going, and that'll tell us in a couple, 2 or 3 days if there actually is a specific organism or not. So in general, for most UTIs, going back to that E. coli being the #1 prevailing pathogen, we want to make sure our therapy kills at least E. coli. And Bactrim is good for that. Your other brand name for that is Septra, Bactrim or Septra. They're combination drugs. They're actually 2 drugs mixed together under one pill. And the 2 submedicines in there are sulfamethexazole, which is shorthanded SMX, and trimethoprim, TMP. Sometimes on some generic packaging, you'll just see those 6 letters, SMX, TMP. All right, but brand name is Bactrim or and again, I tell this in all my sessions. On this exam, you'll get a brand name plus a generic name always. They're not going to give you just one. All right, so you should be able to recognize one of the 2 components of that name. So that's a good choice there. Macrobid is okay. And we like this one if they're pregnant because macrobid does not cross the placenta, so it does not go to the fetus. It stays in the urinary tract. Macrobid or macrodantin, or the generic name is nitrofurantoin. And they might get the other one that helps with some of the symptoms. That's the pyridium, and that's that purple pill, and it's going to make their urine turn possibly that orangish color. And we need to tell them that if they don't already know this, because otherwise they'll call up and be freaking out, ask, who's in charge? They gave me this medicine. My urine's all messed up. So we want to advise them of that ahead of time. So the pyridium is basically, it does two things. It's a urinary analgesic. It helps to calm the very irritated tissues. And it also, depending on the exact manufacturing of it, sometimes it's a urinary antispasmodic, which is sometimes the reason they're having those symptoms also. The bladder and the urethra are like spasming. So it's basically urinary analgesic. All right, take all those antibiotics, do the front to back wiping or washing. All right, so like even if they're in the shower, wash the backside last. Not that you can't take bubble baths or, soak in your favorite bath salt. Oh, bath salts, don't get me started. But we don't want to be doing them every night, okay? Because when you're bathing, you're sitting in a bathtub, the perineum's down there under the water, and those chemicals in there, they might change the pH of that sensitive perineal and urethral tissue some to make it more opportune for pathogens to go up there. And let's also phase it. The longer you sit in a bathtub, the more likely you got a bunch of germs and dead skin cells floating around and you're bathing in it. I know no one in this class wants to ever take a bath again now. So just don't do it every night, okay? Our kidney infection, so our Pyelo. So this is still going to be E. coli because it's still the urinary tract. And it may have started as a lower UTI and progressed up there. But we need to treat this one with a little more seriousness, because there is a potential for urosepsis, renal insufficiency, renal failure, and a full-blown systemic sepsis too. So we do want to make sure we treat this correctly and look for it. They're typically going to have some of those UTI symptoms, and then that something else that signifies there's a bigger organ system involved here, okay? So here's a word for you to put in your short-term memory: malaise. It's a medical term for that run-down, tired, lack of energy feeling that you commonly get with many infections when your body's metabolism, immune system is ramping up. You're just feeling fatigued all the time. It's the better word. A lot of times we put lethargic, and lethargic specifically means something neurological is happening. Malaise is more just a systemic response to it's just that lack of energy and that fatigue. So malaise. And then here's the ultimate risk with these kidney infections. They can go on and actually cause sepsis and death. So this is actually a post-mortem kidney. Obviously, all that pus up in the renal pelvis there, the renal tissues, those are non-functional tissues with all infection there. All right, so we're going to need a urine sample, and when we start thinking kidneys, usually if you're pretty sure it's just a lower UTI, you're just getting the urine in a pregnancy if it's a female. You start thinking more kidney infections, you see us ordering more labs. We need a CBC to look at the white count. Maybe we're starting to light up some SIRS criteria. A chemistry panel, looking at those kidney functions on the chemistry panel, the BU and the creatinine, looking at their electrolytes. Sometimes with kidney infections, the sweats, the chills, they're losing fluids, and they're depleted, they're dehydrated. When it comes to getting the urine for all of our UTIs, we've got to have that, because that's the only way you make any any urinary tract infection diagnosis is urine. And it's completely permissible that you may have to use a catheter. Now, I talk about this a little separately for just a minute, because if you see the word, if they're describing a urinary condition and you see catheter on there, I don't want your brain to automatically go to Foley catheter and think, oh, we're not allowed to use those. Because a lot of places have really scaled that back. If they're talking a urine infection, they're talking about just a straight catheter or the in and out cath, which is not associated with the same risk of infection like a Foley is. And why you need that catheter? Because those tissues are clamped down. You've already got all these other labs back. The patient's in the room for 2 hours, haven't been able to pee. They're on their second bag of fluid. You're like, come on now, we need some urine at some point. Well, I can't go. Okay, we need to get the urine from you at some point. All right, you can try some other things first, but if they say catheter, I want you to think for urine, they're talking just a straight cath. Now for the kidneys, we're going to step up the antibiotics a bit, okay? Typically, you could give Cipro, Levaquin, you could give these for the lower UTIs. They're kind of overkill. You do have the known possible complication of quinolones, of Cipro. It is a known and proven thing, albeit very rare, super rare, but it is proven that you can get spontaneous tendon rupture. Most commonly, the Achilles tendon can just spontaneously snap. And now you got surgery and orthopedic rehab and all that. So if I don't need a big gun like Cipro just for a bladder infection, let's hold off on that. But for the kidneys, we do look at the quinolones as a first-line agent because they do penetrate these deeper tissues. All right, so the two places where Cipro would be the first one would be your kidneys or a prostate in the male, because deeper tissues. Think about the bladder is not really deep inside the body. It's kind of right there, especially on a female, with that urethra only being 1/2 inch long. So think of the kidneys and the prostate being deeper. Let's use a bigger gun there, all right, and let's save it for that. Kidney infections are definitely one that we're going to have them get a recheck on, because if treated correctly, they actually respond very briskly, like in 12 or 24 hours. They feel like a whole new person. However, it's more of a systemic organ. And if they don't respond, again, that risk of potential multiple organs, some type of sepsis, some type of more systemic infection now. So definitely we want to recommend a follow-up and a recheck for these patients. You know, like a UTI, as long as you're feeling better, you're fine. You know, just a bladder infection. If you're fine tomorrow, next day, don't worry about it. Kidney infection, you know, most people will recommend they have someone recheck them. This is also an infection that I would recommend they have their urine redone to make sure it has cleared, especially in our seniors. Seniors can improve from an infection and look fine, but still have subclinical contaminants there that can flare back up. So again, a test of a recheck basically is recommended. We'll do kidney stones. We'll take a break. Kidney stones. So most actually pass by themselves, which means there's a lot of people that don't come to ER for kidney stones. Some people sit at home and, oh, my back was just aching for a couple, 2 or 3 days. Okay, they didn't need to come see us. So we're kind of jaded. We think every kidney stone is horrific, right? Because that's what we see. We see the worst of the worst. All right, there's 2 things I need to address the kidney stone. I need to address the risk of infection and the risk for obstruction. Okay, that's all we really care about in the ER, because those 2 things would make an admission candidate. If you're completely obstructed, that means your kidney's not filtering on that side because of the backflow and the hypernephrosis, or if there's a urine infection with this, because if it's having a problem passing a stone and the urine is infected, that's not going to perfuse or be cleared very easily. So we always have to rule out 2 things, an obstruction and infection with a kidney stone. So we get the CT scan, not so much for the size, really for the ER doctors, just know, are you obstructed or not? Okay. And then we got to get urine at least to make sure it's not infected. I've treated a few of these up front in the lobby when, you know, we're full in the back. People that weren't in excruciating pain, just kind of like walking around, kind of holding their back, just a little uncomfortable. I've treated many people that by the time they finally got a room in the back, the urine was done, the CT was done, we already had the diagnosis, we were able to go ahead and discharge them basically from the lobby or from triage, from our little treatment room up there. Because that's all I had to rule out was infection and obstruction. We're going to use the word colicky. That pain kind of comes in waves or spasms kind of thing. Also, it's kind of pain, they can't sit still, they can't get comfortable. They're just kind of dancing around the room there, right? And the textbook description would be that flank radiating towards the front, and in the guys down towards the groin. Sometimes they'll say it's hurting their testicle, and that's all that's on their mind. So, and that's one reason why when you get your triage or your initial complaint, you want to ask questions about it. You know, if a guy says he's having testicle pain, tell me more. Oh, okay, well, it's in my groin, but you know, it started up here in my back, in my flank area. That makes you more think of a kidney stone, right? So we want to make sure we ask the right questions about that. So there's a picture of the CVA that was on the couple slides ago. We were talking about the Pyelo, where the kidneys sit right behind this little angle here. We might kind of punch them or jab them there. So they might have CVA tenderness of this also from the irritated kidney with a stone in it. And we'll get that urinalysis. At a minimum, the urinalysis and the CT scan. The labs are kind of hit or miss. Depends on the patient. You know, are they at risk for dehydration, a lot of vomiting? Are they running a fever? Could this be a Pyelo with a stone? But at a minimum, the urine and the CT scan. Medicines, I think most of us know by now that Toradol, it seems to work. I'm not going to say it works great. I'm going to say when it does work, it seems to work really great. Like legitimately, if it does work on a patient, it knocks their pain down from an 8 or 9 down like a 2 or less. I've seen pain-free also. All right. I'm going to say probably about a 4th to a third of the time I've seen it not do a thing. All right, I'll always try the Toradol first. If it doesn't do anything, then we'll go to like more like an opiate if necessary. But be careful with Toradol because it is from that non-steroidal family, and NSAIDs are filtered through the kidneys. So if I know someone's got some degree of chronic kidney disease by old records, or maybe I already got a chemistry panel back, I want to be cautious of that Toradol. It's not saying you can't do it. There's a joke we usually say, well, no, some of the attendings we'll joke around and say, nobody's ever bought dialysis off one dose of Toradol. You know, it is possible, but why risk it? You know, and again, you don't need the dose for Toradol. I think you're seeing that change over the last 2 years. We used to give like 30 and 60 to everybody. There's now evidence that says 10 and 15 is just as effective as 30 or 60 with less risk for bleeding, because it's non-steroidal, and less risk for kidney issues. So again, you do not need to know the dose. So if there's an infection, so if there's a pyelonephritis, a urine infection with this stone, they get admitted, because remember that side of the body is not perfusing the same way that kidney. So it's going to be IV antibiotics. And if it's greater than 6 millimeters, now they don't have to be admitted, quote unquote, admitted, but they will need a procedure. All right, at 6 millimeters or more, it's not likely to pass. These people need lithotripsy, they need some type of intervention, a basket retrieval, or whatever they do. It's not going to pass on. Now, in some communities, they can do this as an outpatient. You don't have to admit them. It depends what your community resources are. Up in South Carolina, we had a huge urology group that would actually do lithotripsy in the office. If I could send the patient home and with pain meds, and they weren't puking their guts up, and they had a driver, and they could show up in PO after midnight the next morning, they do it as an outpatient. Some communities, the only place to get lithotripsy is in your hospital, so they would admit them for that. So 6 millimeters or more is really where we make that decision, or at least the urologist, you know, when we call them, hey, it's an 8 millimeter stone. So okay, it's bigger than 6, they got to stay. And of course, you're going to go home with pain meds, nausea medicines, and those urine strainers. All right, I'm not going to leave that up there. Next up is testicular torsion and epididymitis. And these are going to be another high frequency set of test questions. A lot of people see these because they're both testicle problems, they're both testicle pain, and they can kind of mimic one another. I'm going to tell you the easy way to tell them apart is the time of the onset. That's the take home for you. Now, looking at the patho behind it, the torsion, the concern is the risk for ischemia with that interruption in the arterial flow. Now, you'll also get some venous obstruction and the other tubes that go through that area also, but the concern here is that ischemic testicle. And this is one of your standards as far as a time frame. Ischemic pain is going to definitely announce itself within about a 4 or 6 hour window, whether it be a torsion, whether it be a mesenteric ischemia, or an acute coronary syndrome. Excuse me, 4 or 6 hours is kind of universal for ischemic pain. And so this guy is going to show up pretty much soon after it starts. He's not going to be sitting home for 3 days with this testicle pain, because it's going to get very significant very quickly. All right. The best treatment, the best care for this is to get them to surgery and actually detorse this is the word, meaning to untwist it, to restore that arterial blood flow. Now, their presentation, again, look for key words like rapid, sudden, maybe just overnight even. Like they went to bed normal, they woke up in the middle of the night kind of thing with it hurting really bad. Hours, not days. Those key words to kind of clue you in, is it a torsion or epididymitis? And if they're really in like the late stages where it's getting ischemic, they can look like a kidney stone, just look real pale and clammy and just look real crummy looking from the amount of pain they're having, because this is an ischemic or dying, you know, piece of tissue if they wait that long. Now the scrotum could really be anything. It just depends how much of an obstruction you have going on there. It could actually be large and swollen because the venous system is getting included also. So all that blood is congesting in there. So it may be swollen on the affected side. Of course, it's going to be tender as well too from all that swelling and discomfort they're having. Now, specifically for them, now if they just say, if they ask you what test you need, and the only thing that's close is just says ultrasound, that's fine. But if they give you the choice between different ultrasounds, make sure you pick the one that's called a Doppler ultrasound, because Doppler means it's actually a flow study. It's looking at the arterial flow, because that's what's impeded here, or obstructed, or strangulated. All right, some obstruction. And sometimes they can't actually see that it's torsed on the ultrasound, but they can see that the artery is compromised or not flowing. So the word Doppler just means a flow-directed ultrasound. A little more specific. Okay. Now, sometimes urology may want to try and do it manually, not the risk of going to the OR and risk of infection and bleeding and all that. If they try to do manual reduction or to detorse it, make sure we strongly advocate for some significant procedural sedation, because this man has to be really relaxed to let him manipulate that testicle back in a position. Now, whether they do it at the bedside or if they go to the operating room, after they untwist it, they need to do another Doppler ultrasound, because the same test that showed the problem has to show that the problem's been fixed. It's like a lot of times when you're reducing the wrist fractures, or you're reducing the shoulder dislocations on your orthopedic patients, we get post-reduction films. Same thought process here. The Doppler showed us it was abnormal. I now have to show that even if they do it open in surgery, you think, well, they should be able to know if it's untwisted, but that does not always unkink the vessel. You have to prove, we have the technology to prove the flow is restored. We need to do that. So you can get a Doppler before and after. Now, the epididymitis, again, will be a guy presenting with a one-sided testicle pain. This is very predictable as far as the causation for it. Generally, the younger the person, under 30, 35-ish, is going to be an STD. Over 30, 35-ish is probably going to be E. coli. The ENA never puts you on the fence and say, is there 33 and a half years old today? That's not a fair question. If they give you a 20-year-old with epididymitis, you're like, okay, STD meds, gonorrhea, chlamydia. If they give you like a 50-year-old guy, you think, okay, E. coli. All right, so they don't put you right on the fence, and that's one thing just to make your life less stressful about this exam. It's not fair to give you that gray zone in the middle there. All right. So it's showing you where the epididymis is, and it's showing how it's inflamed and swollen and very tender over there. And again, one of the keys for this is the time of onset. This does not start in 2 or 3 hours. Now, the young man may come into triage and say, oh man, it just started hurting. We're always going to ask more questions. All right. So, hey, sir, dude, whatever, tell me, did you notice anything yesterday? Epididymitis, the answer is going to be yes. It may not have been enough to get their attention, but they may have felt some discomfort down there, or some aching, or some pressure or something, but they noticed the pain may not have started till when they checked in, but there was something before that. Torsion, they would be stone cold normal, like the 12 to 24 hours prior to it. All right, so look at time of onset for this. And they could have those urinary symptoms with it also, because if it was an STD, if it is an STD, all right, how did it get to the epididymis? Well, it went up to the urethra, came down through the bladder, and then came down through that spermatic cord there to the epididymis. So they could still have those irritative voiding symptoms also with this. This is one reason, especially in guys, if you think it is a UTI, we can assume that it is. A good clinician will also check a guy's groin, because they may not have enough swelling yet. The epididymis is painful. They may just have the irritative voiding stuff. And it's nice to know that, because the other thing is, if we notice some swelling down there when the clinician examines them, one of their follow-up tests has to be to rule out testicular cancer, because today when they're in the ER, even with a swollen epididymis, we don't know if there's a nodule underneath there. Okay, they won't know until follow-up till that swelling and inflammation's gone, and then typically a urologist or their primary care can re-examine them. And sometimes they'll send them for a follow-up ultrasound to make sure there's not a nodule, especially if the swelling is not all gone. So this guy may come in walking like a duck, kind of like wide-legged, like a cowboy just got off a horse, because he doesn't want his testicles being compressed between his thighs, or if he's like a skinny guy, sometimes the way those skinny guys walk, their testicles can kind of swing back and forth and hit inside the thigh area there. And that's going to be pretty uncomfortable. So they might kind of walk kind of funny because of this. Now, we don't need the ultrasound to diagnose this. That's only if we're kind of in a gray zone. or if that time frame is kind of questionable, which the ENA exam will not do that to you, by the way. But in real life, let's face it, sometimes the patient's history is kind of questionable as far as the circumstances or time around it. So a lot of times in the real world, we end up getting an ultrasound, all right, on all our testicle pains, and that's okay. But on the exam where they have to ask things that only have one best, most right answer, you don't need the ultrasound to determine this. It's time of onset. And once you suspect epididymitis, more than likely it is someone under 30, 35, we need to consider STDs. And so we're getting urethral swabs. We might be getting the urinalysis, right? And depending on the age range and the results, it's going to tell us what we need. So if it's that younger person, it's probably going to be the Rocephin and Zithromax. If it's the little older guy, you know, 40, 50-ish, it's probably more UTI type medicines. All right. So if we do suspect the STD component and do the STD meds, they meet that criteria again, they have to have that test of cure. They have to get re-swabbed at the end of therapy or at follow-up to make sure the germs are cleared. Because remember, gonorrhea and chlamydia can go subclinical. And the same rule about the HIV testing if we are suspicious for STDs. And then we talk about the testicular cancer, they need to have that followed up on. You just can't tell today, when they show up today with a swollen epididymis, what's underneath that enlarged area. There could, and this may be, let's face it, if it's a 20-something guy, this may be the only time for the next 20, 30 years until he gets a job with some real insurance or whatever, that he actually gets any health care and a chance to get assessed for things like this. So the prostate is going to be a bit deeper infection. I kind of alluded to that already. It does sit deep. Now, it's not really deep per se, but it is more internal of an organ. One of the concerns with the prostate is if there's a prostate abscess and that prostate abscess ruptures, that could spread pus and infection into the peritoneum and cause peritonitis. Now, most prostate problems are not abscesses, they're just prostatitis, which could either be an inflammatory prostatitis and still swell up and give them symptoms, or it could be bacterial. Okay, just prostatitis does not mean abscess yet. Abscess is actually a pus pocket. The reason I also have this slide to show you not only where it is, but by showing the proximity to the rectal area, one of the physical things that has to be done for a prostate diagnosis is a rectal exam. The provider is going to put their fingers in the rectum and try and feel the prostate through that back wall there. Now, what this graphic is showing you is a normal sized prostate. It should not be pressing into that rectal wall. Sometimes when it's enlarged, it'll actually be almost, could possibly be almost obstructing the passage of stool sometimes, so large. And sometimes that may be their only presentation is they're having painful bowel movements, trying to pass these large hard stools past this swollen prostate area. Right? Otherwise, the other symptoms for prostate are very nonspecific again, because it's more of an internal organ. So sometimes they just say, I feel discomfort down there. I feel some aching down there. They may not be very specific at all. And sometimes we miss the diagnosis. All right, we usually get urinalysis on these guys. If the urinalysis is positive, then we have to start thinking, well, what else could be causing his symptoms? Let's go do a rectal exam and check that. So very nonspecific. If they've had any prostate issues before, they're always at a higher risk for prostatitis. Tends to be kind of be recurrent sometimes. And what do you know about diabetics infections? They don't always mount the same response that other people do. Diabetics are bad about infectious presentations. Either A, get more of them, or more atypical ones, or with cardiac, they can present with atypical symptoms of cardiac. On that rectal exam, they're going to document the prostate. Does it feel firm? Does it feel hot? It can actually be warm, you know, from the inflammation. Is it boggy? That's describing it feeling like mushy, like an abscess, or like a boil possibly. So we probably started with just a urinalysis and went from there, and then added on some lab tests. Now, if they're not sick, meaning they're not febrile, their white count's normal, their prostate exam is not alarming, they look stable, we probably don't need a CT scan. And I said probably. Let me say the opposite now. If they are febrile, they do have a white count, and a markedly abnormal prostate exam, they are getting a CT scan because that's more suggestive of that abscess, like an appendix could be abscessed and at risk for that pus and that infection to spread. So for my practice, I and most of the people I work with, we typically decide upon the CT based on their labs. You know, are their labs showing there's a possibility for sepsis here? or possibly for an abscess, because the abscess is actually the very, very infrequent cause. Because if there is an abscess, they're going to get admitted, and surgery or urology or whoever, depending on your facility, is actually going to need to go in there and drain that abscess. Abscesses get drained or removed. You don't want to remove your prostate, so they're going to try and drain it basically. And to drain it, they actually have to go right through about where that green arrow is, right through the perineum there to get to it. If they're going home and they're the walking well, they've got some follow-up, things like that, it's going to be those bigger antibiotics again. If it's a younger person, STDs again, you hear that theme time and time again with these GU things. Younger people look more for STDs, are more common to cause GU problems. Well, older people, we've got some alternate diagnoses. So if it's a 50-year-old guy, he's probably going home with the Cipro or the Levaquin. Again, the quinolones, I like those for those more internal type organs, those more deeper infections. Stool softeners, if their presenting complaint was having painful bowel movements, and those antibiotics aren't going to work right away, so they're probably still going to be going home and having some more painful bowel movements. So maybe some providers give them like some Colace once a night to help for symptom relief as well too. Our kidney trauma, it usually is not the sole problem. Okay, let's face it, to actually cause damage, traumatic injury to kidneys, you're probably going to have some other tissues or body parts injured also. Now, the most common ones we see are the lower rib fractures, because the lower ribs protect the kidneys, and if you damage a kidney, you've probably cracked or broke a rib, all right? Or maybe sometimes the bones off the spine, the vertebral processes that stick out from the spine, again, because they overlie the kidney there. But if it's just a kidney injury, most times these do fine. They don't need to go to the OR with the trauma team. Now, if there is some reason to go to the OR, it's probably a bigger problem going on. The other nice thing about the kidneys is they actually have a membrane around them, a capsule. And so even though the kidney tissue may get damaged, like a hematoma or a small laceration, if that capsule is still intact around it, or that membrane, a lot of times that holds it together and causes like a tamponade to slow down the bleeding and can allow it to heal itself. So it just depends upon the degree of the injury. So by itself, a kidney injury is usually not what is the mortality in our trauma patients. The big thing here for the test is the urine. We don't want to rely only on the urinalysis to prove or disprove a kidney injury. We've got to use all the appropriate testing, the ultrasounds or the CT scans also. Now, if there is hematuria on the urine, we better go look at the kidney, but in absence of it does not rule it out. We have to look at the bigger picture. Okay. One of the things we might see is if during our physical exam, after we do our head to toe and then we do the back, we flip the patient, look at the back of them. If we roll them and look on their flank and see this large bruising or ecchymotic area, that might indicate a retroperitoneal hemorrhage, and that's called Gray Turner's sign, G-R-A-Y Turner's sign. Now, it does not prove that there's a hematoma in there. It could just be surface trauma, but if we see it, we better be looking at the kidneys for sure and making sure we're doing a good assessment with whatever appropriate testing we're doing. This is our first, I guess I could have said this under Pyelo, but it applies to any kidney problem, whether it be a kidney infection, kidney stone, renal insufficiency, kidney trauma. Anybody that only owns one kidney, no matter how minor the problem is, they come in the hospital. So even if the most mildest of pyelonephritis, and they look great, they're not septic, but they only have one kidney, they come in the hospital. No matter how minor that renal contusion is, how small it is, there's no other injuries, patient looks great, you'd otherwise discharge them. They only have one kidney, they get admitted. With one kidney left, you just don't mess around and run the chance of something, because that's the only thing keeping them from dialysis, right? And dialysis is good, but it's not perfect. All right, the fast ultrasound, that's the rapid quick look ultrasound either your ER attending is doing or your trauma surgeon is doing to take a quick look at several places. What they're looking for specific to this is that retroperitoneal space. They're looking at that flank area, and if they see fluid there in the setting of trauma, they're going to assume that it's blood, and we're going to go off to CT then and find out is it blood or not. So they want to have a negative fast exam. And it stands for Focused Assessment Sonographic Technique, or Focused Assessment sonography in trauma. It just depends who you read, but it's that quick look trauma ultrasound, basically looking for fluid where it shouldn't be. We're gonna do the same ABCs we do for other trauma patients, our IV fluids, our tubes and our lines, none of that changes. And the same dispositions, you know, if they're unstable, they go to the operating room. Based on their history or the amount of damage, do we just, you know, are they just a short overnight observation, or we admit them, or do we need to send them to a bigger, higher level hospital that can provide more services depending on what they need? The bladder rupture, this is almost always concurrent with a pelvic fracture, and that's the more likely threat to their mortality is the pelvic fracture, because the risk for bleeding with the pelvic fracture. You're not going to die from a bladder rupture. But it needs, if we notice that, we need to say back up and say, hey, we missed something. What other injuries could this person have? And pay attention to that pelvis there. Now, if the bladder was full at the time of trauma, it's more, it sits above the pelvic bone, so it's less protected. And when it's full, it's a solid organ, so it's more susceptible to blunt trauma. If your bladder is empty, it's empty, it's compressible. So these are like the risks that determine with the abdominal or lower abdominal trauma if they're more likely to have it or not. So there's going to be some abdominal pain with this. Again, that pelvic fracture is almost always there, and that may be the only thing they're complaining of is the pain from the pelvic fracture. They may not notice their other injuries even. And they may say that they cannot void. Well, two reasons to that. One, if the bladder is ruptured, there's no urine to come out because it's leaking in the peritoneum. Number two, if you already have the Foley in there, they're not complaining this irritation because the Foley, they're complaining because the ruptured bladder is sitting in this. So on your bladder, there's a sensor that says that either your bladder is full and stretched and you got to go to the bathroom, or your bladder is decompressed and you're good for the next couple hours. When the bladder is ruptured, it's empty, but it's still seeing a signal thinking it's full because those nerves, those sensors have been torn, they're damaged, and they're sending an abnormal signal. So even though you look down the Foley catheter, it may be draining some urine, and the patient says, oh, I feel like I can't go. It's not from the Foley, it's because from the bladder damage. So it's kind of, the mechanism of why they have that symptom is kind of unique to this. Now, the most likely presentation will be this patient who presents trauma, shock from the blood loss, and pelvic fracture. Again, we don't really have a way to directly assess the bladder at the bedside, but we're doing like the pelvic, we're checking the pelvic bones. We're doing our slight compression when we press down and slightly when we press in. We might feel some crepitus there. We might see some instability of the pelvis. If it's a guy, we might see his scrotum filling up with blood with a pelvic fracture. All right. That lower abdominal, that lower intra-abdominal bleeding, it wants to follow the path of least resistance. And in a guy, it's easy for that blood to go down to their scrotum. So you might see this large ecchymotic scrotum, like even losing the landmarks, like you probably couldn't even find the meatus or the penis because the scrotum is overlying it even, it's so swollen. As far as our tests, we don't always see the bladder rupture right away, especially with that pelvic fracture. So if they're stable and they wind up in the CT scanner, we're going to see the broken bones. But with all the blood trapped in there from the pelvic bleeding, we may not see the bladder rupture right away. Sometimes the bladder rupture isn't actually diagnosed until the secondary survey, which to a trauma surgeon, so as nurses, we have our primary and our secondary. Our primary is looking for life threats. Our secondary is our head to toe, basically. In trauma surgery world, the primary is all the things they do in the initial resuscitation. Once they get them up to the unit or out from the OR, they do a secondary review, which is now they go back and say, what all other possible things could we have going on here that were not initially apparent? Looking at patients' risk factors and other symptoms that develop since then. So sometimes this bladder issue is not detected until that secondary period once already transferred out, because let's face it, you're focusing on the pelvic fracture that most likely is announcing itself, their risk for blood loss and instability. So because we're on the male GU system here for a minute, talk about Foley catheters. So for a male, well, for both male and female, if there's blood at the meatus, we don't put a catheter in. But for a male, it's also recommended that somebody check his prostate, because if his prostate is torn off the urethral passage, they might notice on rectal exam that the prostate is sitting too high or too low or too far to either side, and we'd have to assume that it's actually been transected, in which case that Foley catheter is not going to go to the bladder. So for male, we add that one extra recommendation to check their prostate, one of the providers would do that. All right, Bartholin's cyst. Now, in the day-to-day world, I think a lot of us use the word cyst and abscess kind of interchangeably. I want to be very specific. Medically, a cyst does not mean infective. Abscess always means infective or infectious, all right? A lot of cysts are just filled with fluid. Sometimes it's normal fluid. Now, Bartholin's gland can have a cyst or an abscess, so we'll be very specific. We're going to treat them both the same, though. This is a gland that normally sits at either the 4 o'clock position or the 8 o'clock position. Well, it sits in both places, but you're not going to get both sides at once. The most common problem with Bartholin's gland is a cyst, which is not infectious, and it's just that some of the normal mucus that's secreted plugs the duct, and you get this painful swelling. Now, we also have Bartholin's abscesses, where you do get bacteria in there. Regardless of which one we see in the ER, we typically will cover, I mean, obviously if it's an abscess and we see the pus come out and we open it, they get antibiotics. A lot of times with just the cyst, we'll do the antibiotics also more prophylactically or preventatively, because that area's got some inflammation that could then grow some bacteria. All right, so cyst versus abscess, again, it doesn't change our treatment per se or the presentation. They're going to have this very tender one. I mean, because you're basically, that gland is so distended with either the blockage from the infection or the mucus plug, so distended, so they probably don't even want to sit down. Like when you walk them back to a room, they're like, oh, I'll just stand here. Okay, because for a female, that's like, when they sit down, it's almost like sitting right on it. What we're going to do here is we're going to treat it like any other abscess or boil on the body. We're going to numb it up, incise it, drain it. The difference is what we're going to put in it. Every other boil in the body, we put that gauze packing in it, and it serves 2 purposes. One, that gauze packing keeps that clean area we just opened and irrigated, it keeps it open, because if we didn't do that, within about 4 or 6 hours, it would start to seal back together and accumulate the fluids again. So the gauze packing or the gauze strip keeps it open. The second purpose the gauze serves is it acts like a wick. So as the surrounding inflammation around whatever abscess we just IND'd, as that surrounding inflammation comes into that area, the gauze can wick it out through the opening onto those 4x4s or those gauze pads that you taped on top of it. That's a good thing, except in this area. In this area, we want to keep it open so it can drain, but what we don't want it to do is to allow that wick to draw things into this area, because in the perineum, we've got a lot of germs in this area, and if I took the time to wash and clear this out, I don't want a gauze wick to be pulling some of these germs into that clean area I just made. So for this abscess or cyst, we use something different. We don't use gauze, we use what we call a word catheter, and that's just a brand name. The technical name for it is a balloon-tipped catheter. It's actually got a little valve in there, so when you fill it with the air with a syringe and take the syringe off, that balloon stays inflated to keep that cavity open and to keep it from sealing over. But we lose the benefit of that wick action to try and drain some of the fluid out. So this person is going to be seeing an OB doctor probably every 48 hours to have the air withdrawn, the catheter taken out. They're going to re-irrigate that area and then put a fresh one in with a little bit less air. So word catheter is exclusively used for the Bartholin's cyst or abscess. As far as sexual assault goes, the ENA knows that most of us have access to a SANE program to deal with these. So they're not going to ask a lot of questions about this, but there are still some basic universal things that are true. Even if you're a place that sends out every one of your sexual assaults, there's still some basics that are universal that we need to adhere to. And there's some forensic concepts here too that apply to other things, like, your trauma patients sometimes have forensic issues with gunshot wounds or whatever. But as far as sexual assault, the defining characteristic is at some point there was a lack of consent. That's what makes it an assault. It's consent based, okay? And they can present pretty much with anything as far as complaint. You know how that goes? They sign into triage with one thing. By the time you get in the room, it's a whole different story, right? So the magnitude, the severity of the complaints or the story does not always dictate what it is or isn't. As far as the assessment goes in these patients, I've heard of some hospitals where basically they sign in sexual assault. It's like, some places transfer them out right from triage, like they don't even get to see a provider. I don't know if that's truly legal or not, but at some point, even while waiting for transport or the sheriff or whoever, whatever you do, we do have a role to, at least my understanding of EMTALA is at least to do some basic assessment to make sure you don't have a true medical emergency also. But as far as the assessment for the sexual assault, it's going to be dictated by the evidence collection kit that's provided. So they're not going to ask questions on that specifically because, let's face it, the kit you use at your facility, if y'all do it, and mine may be two different kits and have different forms in there, a different history, a different intake form, a different assessment form. Okay, so the kit will dictate what you need to ask, what questions, what documentation needs to be done. I've seen this about their level of consciousness on the exam before a couple times. So we don't want to let their behavior dictate, do we think it's a sexual assault or not? Because one of the questions I saw was basically, it's like a girl was like on the cell phone and yakking it up with her friends. Oh yeah, I've been raped. You know, what do? You treat it as she's been raped or sexually assaulted until proven otherwise, because different people have different coping skills with stress and trauma. And some people are kind of in a bit of denial. Some people may be just crying and they can't even talk to you, and their best friend is there with them trying to keep them, you know, comforted and trying to tell a story for you. So their mental state, their level of consciousness, their whatever, their behavior does not dictate sexual assault or not, because different people respond differently. Any diagnostics that are done for this are going to be provided by the kit. Now, if your provider decides they need stuff, like they need to make sure that the girl is not, you know, anemic, then you have to use your own stuff from your own hospital lab or supply cart. Anything for the crime lab has its specific ones that can vary from place to place. Sometimes the state crime lab wants a CBC also, and their tube may be different than the one you routinely use. You use the one that's in the kit there. So not a lot of questions about the actual diagnostics because it can vary from place to place. One universal, it is fair game, is using the black light or the ultraviolet light. And part of this is whoever's doing the exam will go head to toe with this black light, and anywhere that glows is assumed that it could be semen. And of course, that would have some DNA of the perpetrator, and that area gets swabbed and packaged in whatever the forensic kit gives you. There are other things besides semen that light up. That's not for the examiner to decide. You just, if it lights up, you swab it, you label it, you document what part of the body it was on, and package it. Okay, because it could potentially be DNA. Clothing goes in paper bags, not plastic. That's a universal forensic concept, whether it be your gunshot wounds, your other violent assaults, your sexual assaults. Clothing goes in paper bags, because if you put it in plastic, there's humidity in there that can break down the DNA. You can get some bacterial growth sometimes. So paper bags. And then of course you got to put some chain of custody label on there, and those could vary from place to place. Your labels may look different than mine, but you know, chain of custody is going to basically include everything: who you hand it to, what time, the condition, just everything you think of is going to be on there. They'll get their standard STD prophylaxis, so you can expect to see the Rocephin and the Zithromax. Now, as far as the Plan B or the morning after pill, that's on a case-by-case basis. The provider needs to talk to them about this and explain the risks or the benefits to it, because some girls, it's such a high dose of the estrogen, it could actually make them sick. Things like that. Some, you know, not everybody that's got sexually assaulted nurse, they says, hey, I want to get rid of this potential pregnancy if I have one. They might be like, okay, well, you know, we'll see what happens. So the STD medicines are pretty much mandatory. As far as the Plan B goes, there are two things that are actually on the FDA label. You must have a negative HCG. Okay, so the morning after Plan B is contraindicated in pregnancy. Okay, because you're giving it to prevent pregnancy. You're not considered pregnant until that fertilized egg sticks to the uterine wall. And when that happens, you start to release the HCG. So could this girl have a fertilized egg traveling down the fallopian tubes? And yes, if the HCG is negative because it's not implanted yet. So is this an abortive? Again, not a discussion for this class. It's a preventative. It prevents it from implanting. Okay. So for what it is. The other rule about it is you have to give it within 72 hours. Sperm semen doesn't live beyond 72 hours in the intrauterine compartment or the cervical area. And so after 72 hours, one could assume if you're not pregnant by now, you're not going to get pregnant. All right. And it's just going off label. It's not labeled for use beyond that time. Trauma in pregnancy. The number one reason the baby dies is because the mother dies. So everything we're going to do will be to keep the mother alive. That will give the baby the best chance for survival. Our priority is not to call L&D down and all this. Our priority is first to assess the mother, make sure she's going to live. The second most common reason is mom goes into shock. So those are our two priorities of care. Keep her perfusing and keep her alive. Best chance for baby survivability. And anything we need to do to accomplish those goals, we're going to do. There's a lot of things that happen as far as changes physiologically in pregnancy. And we could probably spend 30 minutes talking about these alone, but we're not. The only thing I like to really bring out with this, two things. She's probably going to be hyperventilating normally. Now, a lot of our trauma patients hyperventilate to offset their hypovolemic shock and their lactic acidosis they're going into. In her case, it just has to do with her altered physiology. So we don't want to look at her hyperventilating and think, oh my gosh, she's in shock. It could just be from the pregnancy physiology. We'll want to look at our other markers, or blood pressure, vital signs, or hemoglobins, etc. The other one is the GI concerns, especially if she's late-term pregnancy with this 12 to 14 pound or more uterus pressing up on her stomach. She's more likely to vomit because, you know, let's face it, her stomach's not as big as it used to be because it's being pressed on. And so the fast food hamburger she had just before she crashed her car is more likely to come up and out. And a lot of our trauma patients stay flat on their back the whole time. I call it the aspiration position. All right. The other thing with GI is some of the pregnancy hormones that are released during pregnancy, they slow her GI system from emptying. So that quarter pounder of cheese is going to stay in the gut longer before it goes into the small intestine. So again, another increased chance for aspiration. So let's clear her neck, let's clear her C-spine, her back, and if we can, let's get her sitting up some to protect that position and get that uterus off of her upper GI tract. Whatever tests I need to do to make sure she's going to live, we're going to do. Okay, now we're always going to ask ourselves, again, going from that safe to less safe thought process, would an ultrasound give me as much useful information as a plain x-ray would? And if the answer is yes, then go with the ultrasound. Would just a couple plain x-rays, just a plain chest x-ray, just a plain KUB x-ray, would that tell me what I'm looking for as good as a CT would? And if the answer is yes, then just go with the plain x-rays. That's obviously less radiation. So that's the thought process on that. It's kind of a subjective call there, but at the end of the day, it's still a take home. If I need to keep mom alive, and the only thing that will help with that is identifying her problem in the CT scanner, then I need to go to the CT scanner. And yes, that's more radiation, but remember, if she doesn't live, the baby doesn't live. And anytime she's in trouble or unstable, she goes in that left lateral decubitus position again. And actually, here's the data. When she's laying flat on her back, you can actually compromise 30%, a third of her return blood flow to her heart, which is 1/3 less blood getting to the heart, getting to the lungs, getting out to the left side of the heart and out to give her a blood pressure. So she can be pretty compromised just laying flat on her back. So we're going to move her to her left side and get that uterus off of there. All right. Any questions about OB stuff?